So I think since morning, this topic, the guided growth, has been emphasized enough. So we have seen many cases to the degree that I have nothing to say. So this is we believe that the growth is a dynamic process. So when the kid is born, it's like in virus, and then the limbs start to straighten gradually to the slightly valgus in the adolescent life. So we try to take advantage of that and guide the growth or control the growth to the desired direction. And that's the basic idea of the guided growth or growth modulation. And it's basically based on this law, Houter-Volkmann law, which clearly states that the side of compression, the growth, bone growth is inhibited, while it's stimulated in the side of tension. So what will happen if we let's say control or tether one side of the growth plate that we think it's more active or growing faster than the other, to allow some time to the sick physes, or let's say sick hemiphyses, to recover. So that's the basic idea. And that's what happened here, if you see. And you can achieve this task using many devices. Classically, we use the clips or the staples, and nowadays we move to the 8 plate or the tension plate, tension band plate. Transphysial screw were used, and still some people using that. So in the coronal plane, we talk about the genovarum and genovalgum. So basically what you do, if this genovarum, you go to the side that we think it's growing faster, and we try to halt the growth until the recovery is there. So you see, this is case of Blount disease. And what's striking here that we believe that the Blount disease is disease of the proximal tibia. But if you see here, the surgeon chooses to do the distal femur. So it's not pure proximal tibia. It's the distal femur is slightly involved. So that's what happened. So, and you can do it also for the genovalgum, the same. Okay. In the sagittal plane, we talk about the recurvatum and procurvatum. So this is an example of procurvatum, soft tissue contracture of the knee, and you need to put the tension plate on the anterior side of the growth plate to allow the posterior side to grow. And you need to make sure that your tension plate is not interfering with the patellofemoral articulation. And this is the configuration of the tension plate. This is using the transphysial screws. And this is using the tension band plate. One more example. So there are some considerations that you need to take into account. Growth potential. So since your treatment is based on the growth velocity, so you consider that you try to do it in earlier stage. If the patient is about to, the physe is about to close, you don't expect too much. But it's a good thing. I think it's more, I would rather do this than doing osteotomy, because this is somehow minimally invasive. So growth potential is one consideration, and you take in consideration the undercorrection and overcorrection. And we know that we have rebound phenomenon. Once you remove it and you think you achieve the task, you start to see the recurrence. So because of that, they develop this concept, which is sleeper plate. So this is one case of overcorrection you see now. So the This is after surgery, and this is during correction. After some time, it's overcorrected. And maybe this is desired, since we know that this patient will have some recurrence. This is case of sleeper plate. So suppose you do the tension band plate, and after some time you achieve the correction, and you are afraid of recurrence. So what you will do, you go to the surgery and you take one of the screws, usually the metaphyseal side, and make sure that you release the tension plate from the soft tissue, because it can work as tension or tethering device. So that's, the surgeon here is trying to elevate or release the plate. Once you feel there are some signs of recurrence, you can go back to surgery and pass the screw again. And you do it one more cycle. So that's the idea of sleeper plate. It's one way of tackling rebound phenomenon. Yeah, that's it. So that's all. Thank you so much.